All right, infectious disease. This is the class for October 2021. This class is a half-hour class, distributed education, fill out a 1085 and turn it in and get credit for it. Infectious disease, this is kind of a weird one. Guys, it covers kind of a lot of stuff, and to me it's kind of all over a little bit, but I tried to break it down to where it made some sense. The main thing they want you to cover is your main types of infectious diseases that are out there that we kind of deal with. So I broke down the ones that are most common for us, how you avoid those, what we do to stop them, and then it gets into sepsis, which doesn't really fit with this completely, but it's the main kind of treatment infectious disease that we generally deal with in the ambulance, I guess. So they want to cover it. So we're going to go over how to detect it and then how to treat it. The big one right now, obviously, is COVID. That's out there. It's kind of new. We'll talk a little bit about it, but I kind of broke these into sections, or label up here in sections. These are kind of your, I guess what I would call old school, your traditional ones that are out there. The traditional stuff, Hep C, HIV, TB, that's the big ones that we've dealt with for a long time. Then you have kind of your middle ground, newer ones that have came out. I can't draw right now. The newer ones that have came out, I don't know, in the last 10 years have become a big deal, which is MRSA and C. diff. You see that a lot. MRSA being antibiotic resistant staph, and then C. diff, kind of a hospital thing more than a ambulance thing, a hospital and nursing home. You'll see those two a lot. And then your the flu and COVID. Flu is not new, COVID's new, but these are mainly airborne, is how you get these. So all of this stuff, each level, we have ways that we deal with it. Hep C, HIV, TB. Hep C, HIV, if you're not familiar, that's kind of where gloves became the big thing, was when these become prevalent. You got it where everybody was wearing gloves all the time. TB, we get a test for. We just got them the other day, right? You get the test in your forearm, and we check on that. It used to be a huge deal. There's still people that deal with it. Very hard to get rid of once you got it. So very hard to treat. So we test for it annually when we get our flu shots. MRSA, C. diff, like I said there, MRSA and C. diff are mostly more for the hospital. We don't deal with them as much as far as treatment in the ambulance. We will transport people with both of them. But all these infectious diseases that are out there that we deal with. Okay, so how do we prevent infectious diseases? Really from kind of listed different things that are out there. We have vaccines for a lot of these, and then we have tests for the others. Hep C, now they have a treatment for it, which is new in the last couple of years. They didn't have a treatment for it for decades. It was almost a death sentence for you when you got it. So it's really very important. Hep C transmitted by bodily fluids, mainly blood, but other bodily fluids as well. So that's, like I said, that's why we wear gloves all the time, iPro in some cases, and why it's very important to wash your hands after any time you come in contact with that. HIV, very similar. TB, airborne. MRSA, mainly transmitted through open wounds. That's where you're going to get MRSA. Where in the nursing homes, the reason it's so prevalent is because of people that have ports, they have surgical sites that are open, etc. In the hospital, same thing. C. diff, mainly fecal matter that C. diff is transmitted in, but it can be transmitted other ways. You'll always see C. diff precautions all over the door. Same deal with both of those as well. Gloves, iPro, etc. for those. Flu and COVID, we have vaccines for. If you don't want a vaccine for it, we have tests, especially for COVID. You can get tested routinely to make sure that you don't have it if you don't get the vaccine. Gloves, still important with COVID, but COVID we found is not transmitted very easily on surfaces. Everybody was disinfecting ridiculous amounts in the beginning, thinking that it was, but it looks like it's not transmitted that easily on the surface. It's kind of like HIV, where it dies almost immediately. But gloves, iPro, mask. Somebody said this the other day, I think it was Jeff Cox was talking about this. I said Hep C and HIV, something when you started wearing gloves for those things, and then the gloves kind of never went away. We always wore the gloves. We always wear the gloves now. It's like a huge deal. You'll get, if you don't put your gloves on, like in the registry test, you'll fail, right? You have to like act like you're putting gloves on or put them on. You are A lot of people think that, thinking back now due to COVID, we probably should wear masks when the flu season is on. Think about the amount of time that you have people at the fire department that are off work for the flu, and then they bring it to the station and give it to all of us when they don't take the day off, right? And how many people that are off, and then you take the flu to home to your kid, and then you give it to them, and then they take it to school. We probably should wear masks all the time. I don't know that we ever will, but there's a good chunk of people out there that think we'll never stop wearing masks. We may wear masks forever in the ambulance. I don't know. iPro, this is something that I got into. For people familiar with me, I got exposed to Hep C one time pretty bad, and it all would have been prevented if I'd had iPro on. I don't know. It was kind of an accidental thing, but I should have had iPro and never would happen, but I got blood in my eyes. But especially when you're talking about, even with COVID, but when you're talking about intubating people, it's a really good idea to wear iPro when you're intubating someone. You're right there in their mouth, and we've all probably had blood spit on us out of somebody's mouth, or vomit, etc., some type of body fluid that's came out of someone's mouth while you're intubating and got it on your face. If you do this job long enough, you definitely will. So good idea to put some iPro on when you intubate. But masks, gowns, COVID's a big one. C. diff can be as well. Wearing gowns on calls. The other option for gowns are really meant to be worn when you don't have the ability to change your clothes. They're really meant for like a hospital setting where you're wearing them all day, or every time you go into a room and you take it off and throw it away in the bin next to the door. So you have other options to that, like disinfect your clothing, but these are our kind of main staples. These are our kind of passive things that we do. We get vaccines and we wear this passive protection: gloves, iPro, mask, and gowns. Disinfecting the ambulance. The big one, disinfecting the ambulance, is make sure that you use some type of approved cleaner. Just cleaning the back of the ambulance with something else like glass cleaner or whatever is not necessarily going to get it done. COVID, the flu, HIV, Hep C, these things are super easy to kill, and glass cleaner has ammonia in it, and it would kill it. It's actually, ammonia is one of the things that will kill this. MRSA is probably the hardest one of these to kill, but most of the stuff is killed easily when it's outside your body. Right? MRSA becomes very hard in C. diff to get rid of once it gets inside your body. So if you kill all the stuff in the truck and nobody gets it, it's a lot easier. Big thing for that, disinfecting the ambulance, right? So Lysol, something we use a lot. Citrus cleaner, something we use a lot. And purple wipes. All those improve to kill pretty much everything on the board here. The big thing with all of this is that if you don't let it air dry, it doesn't work. So if you, for example, if you spray the citrus cleaner onto the bench, and then you wipe it completely dry, it didn't kill it. It's probably 50% effective. If you spray it on there enough that when you wipe it down, it's still wet and it air dries, you killed it. But if you spray it twice and wipe it, and it's no longer wet to the touch, and you just dry it all up immediately, it didn't kill anything. The CDC provides exactly how long it takes. Each one's a little different. The general rule is 5 minutes. If you take a purple wipe, you're at the hospital, you've all done this, you wipe down the bed, those beds get really wet, right? So then you take this towel and you dry it off because you're trying to hurry. That bed's not disinfected. There's still stuff on that bed. Okay, so you have to let it air dry. If you do wipe it down, as long as it's still wet and it needs to air dry, you're okay. But if you're drying it off with a towel, it's not killing it. So make sure that you let stuff air dry. If we don't have any of this, the old reliable that still works is bleach and water. You don't see this used as much anymore. It's the go-to. It's the standard, actually. It's the go-to that's out there, but bleach and water concentrated 10 to 1. So 10 parts water, 1 part bleach, and that kills everything. So moving away from this kind of prevention of this stuff, the infectious disease stuff dealing with treatment is more sepsis and the treatment of it. So sepsis being the systemic infection. You have some type of infection for whatever reason, and it's went global, and so we call it sepsis. Sepsis is the new thing that a lot of people, it's kind of like we used to study cardiac arrest, we studied stroke, we studied trauma, kind of probably started with trauma, and went to cardiac arrest, and then went to stroke, and then now sepsis is the new big killer that's out there. Depending on, we don't really know, depending on which data you look at, it's probably the top killer of people in the world. It's becoming that. It's moving to that kind of global thing. We have a lot of problems with it. A lot to do with how kind of the assembly line, corporate fashion of how our healthcare system is ran. You have people moving through the hospital so quickly. You have a lot of different infections such as MRSA and other variations that are resistant to antibiotics. It's getting harder and harder. You have a large prevalence of antibacterial soap being used everywhere, so and a whole lot of factors in it. But sepsis is climbing the charts as far as killers in the world. Which is kidney disease. Oh no, that's flu. Okay, so killers that are out there, a little information I thought was cool. The flu, people are like, oh, it's just the flu. The flu kills the 8th leading cause of death in the United States each year. Kills more people than kidney disease or suicide. It's above those. Okay? That is how many people die from just the flu. Okay? Sepsis on this, it says it's somewhere between number 1 and number 3 killer in the world. So becoming a big deal. They're starting to kind of chart it or collect the data on it and look at it and treat it as, that's how we do it. If you want to get better at something, we start to look at it and then we establish kind of performance measures that we look at, and whether you do this or don't do this. You see they have like a sepsis checklist at the hospital, just like the stroke checklist and all this other stuff. So it starts with us out in the field. So there's a checklist for us that's in your protocol. Right at the very top of it, it literally says these things. It has the sepsis criteria. So the first thing you need is a known or suspected infection. Okay, if you have that. So like the easiest way to figure that out would be they have a fever. Right? If they have a fever, then they probably have an infection. Or they're at a nursing home, they're in an area where infections are prevalent, or they're prone to UTIs, etc. All these things. Like a nurse telling me, I think she has a UTI because she had one in the past. Suspected infection. Or she's being treated for a UTI. Really easy, right? So we have a known or suspected infection. Once we have that check mark, I need 2 of these to declare it sepsis. Okay? Most of the time, you'll get all of them. But high temperature, right? So anything above normal, if you have a high temp, I get a check mark. Have a high heart rate, right? So according to the protocol, the number is 90, not 100. Anything over 90 is considered good for sepsis. Most people, they think of tachycardic, it's over 100, but I just wrote high heart rate because I like the high. And then the respiratory rate will be high. Okay, so I have a high respiratory rate, and then the last one, a low blood pressure, right? If I get all 4 like I just did, there, obviously we know it's sepsis without a shadow of a doubt, but according to the protocol, we have this one, we need any 2 of these, and it's sepsis. Okay? So once we get sepsis, how do we treat it? Once we declare this as sepsis, how are we going to treat this? Okay? Very easy treatment for sepsis and very important and often very misunderstood and not done correctly. Okay? This is something that's changed a lot in the last probably even 5 years, definitely the last 10 years. It's one of those things we're not always up to speed on. Okay, so alert the hospital early, let them know as early as you can. Just like you would with a stroke or whatever, do a sepsis alert and let them know, hey, we have a patient that is septic and we're bringing them in. Start large bore IV, right? So 20, 18 above. Okay, so start a large bore IV and automatically start a fluid bolus. The first bolus should be a liter of fluid. Okay, so this is the time that we dump the fluid to people. Okay, so we give them a liter of fluid. By the protocol, it literally says consider starting a second large bore IV and running another bolus at the same time. Okay, so they want you to move fluid so fast, they're telling you should start a second large bore IV. And give another liter of normal saline. Okay? If you're looking to try to get 2 liters of saline on the way to the hospital, or as much as you can, up to 2 liters, and then consider Levofed. The rule of thumb I was always told, the protocol gives you a lot of leeway on it. My rule of thumb was explained to me was if you start 2 IVs and you start bags on both sides, once you get to a liter, if they're still hypotensive, they need Levofed. Right? You really have to bolster their blood pressure. Okay? So, but we should be considering Levofed on sepsis patients. If you have somebody that's not responding to dual large bore IVs and saline running on both sides, they definitely need some Levofed to keep their blood pressure up. All right, that's where the treatment's gonna be in the hospital. It is lots of fluid and then antibiotics. And this patient's gonna go to the ICU. So it should say down here, appropriate hospital. Right, a patient that has sepsis cannot go to a local hospital. They're going to spend a long time in the ICU. And according to the statistics, if we get the fluids to them quickly, we start this, we keep their blood pressure high and we keep their blood pressure up, and we give them the fluids, they have a pretty good chance of survival. They're gonna need a lot of time in the ICU and a lot of antibiotics. So if we take them local, we don't give them a lot of fluids, we're really putting them behind the power curve on the treatment. Right. So guys, any questions on this? Infectious disease, pretty straightforward, pretty easy. All good? Mickey? Yeah. Are you sure?
I think I'm okay right now.
All right, that's all I got.